All right, that was an outstanding discussion about our first case. We have another patient now coming in. This is a 25-year-old male with left chest wounds after being struck by the car in the coffee shop. So let's take a look at what he looks like when he first presents to the emergency department.
Peter, what do we got?
Deep lacerations to the chest, decreased breath sounds on the left.
BP's 100/60, pulse 120.
Come on, help me, will ya?
Okay, what's your name?
Screw that, I'm hurting here. I want to speak to the manager.
Okay, he wants to speak to the manager. All right, so this guy comes in, deep lacerations to the left chest, decreased breath sounds.
Mm-hmm.
What diagnoses would you be concerned about?
So with that specifically jumps out as I'd be concerned about thoracic trauma, namely a pneumo or hemothorax on the left side. That said, he also is at risk for all the same things that we saw in the previous patient. So he, just like the previous patient, is agitated.
Mm-hmm.
And again, you have to assume that that's physiologic and not just that he is a loud person. So you assume that there's actually something physiologically very wrong.
Very good. And then, a common dilemma for us is you see a laceration to the chest. You're not sure how deep it is, and so you want to assess its depth. And I've seen doctors come in with a Q-tip or a probe to assess the depth. Is that a good idea, a bad idea?
No, you should never do that. And the other thing that people will do, in addition to probes and Q-tips, is to stick their finger in wounds. And just to address the reason to not put a finger in the wound, a person who has had a penetrating injury to their body could very well have pieces of glass or metal, and you could actually injure yourself in the process of probing a wound. And if that person has a communicable disease, then you could acquire it quite easily through that mechanism, so you shouldn't do that. In terms of putting probes in there, you can actually potentially worsen an injury, and it really won't help you with any of your decision making. Even if you have a penetrating wound that makes it all the way into the chest, but you don't have a pneumothorax, you don't have a hemothorax, you might not necessarily do anything. Mm-hmm. And likewise, if you have something you've probed and you assume it doesn't go deep, it might be that you're wrong, and that in fact it does, and the person does need a chest tube.
Sage advice. All right, let's see what happens next.
All right, 1% lidocaine.
Did you forget your trauma gown?
Tell you about it later.
Pulse 92 on 4 liters.
You want any medications? Do you have any allergies?
No, you sons of bitches. Just give me something for the pain.
All right, titrate 4 of MS.
Yeah, you win, bud. Morphine?
Thorsil's ready.
All right, hook me up.
First crit 35.
Okay, first hematocrit is 35, pulse ox is 92%, and they're placing a chest tube. So in this patient, what is the indication to put a chest tube in? What's the indication for tube thoracostomy?
He has decreased breath sounds and is at risk of having a pneumo or a hemothorax.
Okay. So clearly, as Dr. Steinmeier mentioned, this patient, decreased breath sounds, risk for hemo or pneumothorax. The treatment for that is to insert a chest tube, and so that was the reason that they were doing that. And then as you're putting it in, mm-hmm. what do we look for?
So first of all, when you're getting ready to get into the pleural cavity, once you pop into the pleural cavity, you should be taking special note of whether you get a rush of air. That would suggest to you that you potentially had a tension pneumothorax present. Then, of course, what you're looking for after you place the chest tube is whether or not you get any return of blood suggesting hemothorax. You also would hope that you would see a reversal of any parameters that were not normal. For example, if a person was tachycardic from tension pneumothorax, that should get better when you relieve it. Or if they are hypotensive and you have blood and you're giving blood and you're taking blood out, that you actually have a patient who's looking more stable.
Okay, so not only physical signs from the patient of air or blood, but mm-hmm. do they actually improve from this intervention?
Right.
Pressure's down to 70, tachy at 130. He's bleeding out. We got 1,000 cc's in the thoracic.
Put the blood on the rapid infuser, give him what he's lost, and keep him 4 ahead.
So heart rate has jumped now to 130. There's increased bleeding within the thoracic. So they are advocating for taking that blood from the collection device and retransfusing the patient. Is that something that we can actually do?
So we actually do that at times, but you have to actually plan to do that from the outset and use appropriate equipment and make sure that you actually have an anticoagulant in the device that's collecting the blood. And then just as importantly, before you can retransfuse that, it has to go through special lines and filtration systems. So it's not something you would do if you're not prepared or set up or trained on how to do it.
Okay. That's very important. So you can't just run over to the chest tube collection device and then hook it, put it into a bag, and give it to the patient. That potentially could be harmful?
That's correct.
Okay. And then an important question now in this particular patient is a lot of blood out of the chest tube, having some hemodynamic instability. Should we go to the operating room with this patient or continue to manage them here in the emergency department?
Yeah, so this would be a person I would personally take to the operating room. There's a loose cutoff that's discussed in ATLS that says if you have a loss of 1,500 milliliters out of a chest tube after a placement, that's your threshold. That said, that threshold is flexible. If you have a patient who's becoming increasingly unstable and you have 1,000 liters out of the chest, presumably that person is actively bleeding, and it probably will be 1,500, or if it's not, it could be your tube's already clotting. So you have enough clinical parameters here to know that he's bleeding. It's also important to consider that in evaluating this patient, they've noted that he has lacerations over his chest, and so everyone's very focused on his chest. But he sustained a mechanism where he could have abdominal injuries as well. And so he could very well be bleeding into his abdomen, and that's not been assessed yet. And so I would take him to the OR with the plans to do a thoracotomy and also probably explore his abdomen if there's any question.
So where is the boundary of our abdominal cavity when we're looking at our chest? How high does it rise, and how do we know?
Right. So in full exhalation, the dome of the diaphragm can reach up to the level of the nipples, and so that gives you an idea that the abdominal organs are very exposed to injury, which we normally consider to be the thorax.
So a lower thoracic stab wound could actually take out your spleen in addition to your lung or your heart.
That's right.
Okay, very good. All right, we're going to close with case number 3, a very, very interesting case. So let's get started.
30-year-old woman, pregnant, MVA, T-bone with passenger space intrusion, no pulse in the field, traumatic floor arrest, 10 minutes down, couldn't intubate.
1, 2, 3.
Oh man, she's gotta be full term. Shouldn't he take over CPR?
I need an 8-0 ET tube now. See if you can give me some suction. Let's set me up for a central line, 4 units of ONEG, and somebody get another doctor in here.
Lay, check for a fetal heart tone. Asystole on the monitor.
Okay, cricoid pressure.
IV's blown.
All right. I'm in. Give me an epi to put down the tube.
Blood's here.
Hanging on the rapid diffuser. I'll throw in a subclavian.
She looks full term. Fetal heart rate.
Can't find it.
What's the mother's rhythm?
Asystole. We got her intubated.
Any pulse in the field?
Paramedic said no.
Downtime?
We're at 12 minutes.
Okay, a very, very scary case. A full-term woman who's pregnant, full arrest after motor vehicle accident, down for 12 minutes. They're doing CPR. They're trying to revive her, but so far it's been unsuccessful. What do we do in this circumstance?
Right, so it's always more complex with a pregnant patient. You actually have 2 patients and not just one. It is always important to remember that when you have a circumstance of having a pregnant patient, that you really do have to focus on the mother, and you can't forget that, because if you do, the fetus will be at risk. In this case, however, it looks like the mother is not going to survive, and so as you're thinking about the 2 patients, you can't get too distracted by the mom, and you do have to focus on the fetus as well. So the mother sustained blunt trauma and arrested in the field and is asystole on arrival. All of that is associated with a survival rate of not 0, but pretty close to 0%. In that setting, attention then should turn to the patient who will survive, which is the fetus. And so in this case, she should have a post-mortem C-section.
Okay, and that's obviously a difficult decision to make in these circumstances. I find, in my own mind, I think the 2 difficult sort of leaps to take with regards to trauma patients are deciding that you can't intubate someone and you have to do a surgical airway and not continuing down that path of failing. And here again, it's giving up on one patient to try and save the other patient. And I think it's really tough. Any advice on making those kinds of decisions? Yeah,
you have to be really disciplined when you're thinking about this. And once you've categorized this as 2 patients, and then that first patient, you're determining whether you can save or not. what is generally done, if you just consider the adult patient alone who comes in, who's been asystolic in the field, is you make sure you give them their shot. You get large bore peripheral IV access. You give them blood. You place bilateral chest tubes, and you see if you get anything back. In her case, I would doubt that would happen only because she's blunt trauma and it's already progressed to asystole. But if you are disciplined about giving yourself those parameters, and then as you're going through that process, you should also be honest with the findings you get from that. And if you hold yourself to that process, that helps you to deal with the difficulty and the challenges that we encounter as practitioners who have to deal with challenging cases.
Well put. Let's see what happens in this particular circumstance.
We're at 12 minutes.
The mother is dead.
Wait, why can't we try,
No, she's dead. We need to get the baby out now.
All right, subclavian's in, go with the O-neg. Jody, keep up compressions.
I need retractors.
Get that baby warmer in here. Open a cut-down tray.
No time. In your hands. Hold it open like this.
All right, chest tube, 32 French.
I'm opening the uterus. Bend the scissors.
Bulb suction. It's a girl. Come.
Okay, they took your advice and at least saved the baby. This has been the initial management of trauma patients, our expert analysis with Dr. Kristen Staudenmeier, one of our trauma surgeons and trauma experts here at Stanford. I want to thank her for her outstanding discussion of these very difficult cases.
Thank you.